we can get started now that Tim has joined us. Thank you for holding tight. Thank you for tuning in today. We've got Dr. Claire Steeves and Professor Tim Spector, who will be talking through some of the hospitalization data that we've seen and the risk factors associated with those who've been hospitalized for COVID-19, and talking about some of the wider issues and why some of these healthcare concerns arise. Tim is also going to briefly talk about some of the changes to the website in the data that is presented, as well as we'll get into some of the questions later about the uptick in symptomatic cases and why that might be relevant around some of the new symptoms that have been recorded. So just a quick introduction from Tim and Claire, and then we'll get straight into the data. Tim?
Hi, my name is Tim Spector. I'm Professor of Genetic Epidemiology at King's College London and the lead investigator of this COVID Symptom Study. Claire, introduce yourself.
Yeah, so I'm Dr. Claire Steeves. I'm a senior clinical lecturer and a consultant geriatrician, and I've been deeply involved in all of the research that's coming out of the COVID Symptom Study.
Great. So Tim, we've made some changes to the website today. The data science team at King's and at Zoe have been working really hard on this. Do you want to talk through why we changed the website and what data we're presenting now?
Yeah, so those of you who have been with us for the last 2 months, the journey, will have noticed that we were looking at what we call the number of cases that we were estimating were in the country. And at its peak, that was 2.1 million people. And it has dropped down to our estimates by about tenfold, and has been fairly stable for the last 2 weeks. And we're getting estimates of around 200,000 people. That hasn't really changed much. And we were asked by the government and various other people to start working out more precisely how many new cases per day there were, rather than just this general figure, which was really good for showing rates of change. But now we're in a sort of fairly flat scenario, wasn't very sensitive to showing ups or downs. And so this is why we've come up with this new metric, which is the daily number of new cases of COVID, which is actually based on all of you who've actually had positive swab tests. So because we're working with the Department of Health, we're able to send out lots of swab kits, and most of them are negative, but some of them are positive every day. And we know from about 1 million people that we're testing every day, some people are testing positive, and that's giving us over this interval of 2 weeks, pretty good estimates about where all these new cases are occurring, and out of this base of 1 million people. And this is why we've got these figures here. And by then taking the list of people from the million and extrapolating up to the 60 million or 50 million population of England at least, we get estimates of the actual number of daily cases there would be if the same rates we see in our group are seen in the whole population. And that's where we get this figure of just under 10,000 cases a day, which actually matches the government's figures provided by the Office of National Statistics, where they're doing fortnightly random swab testing. So in slightly smaller numbers than ours, because we've got a base of 1 million people, and they're just doing around 20,000 people intermittently. So it's really good to have these figures, which are now matching up with from the different sources. So we're pretty sure they're accurate. And you can see here we've got differences across the country. We're having a range here because obviously numbers get smaller when you break it down into these regions. But you can start to see some differences. There's definitely something going on, a difference between the southwest, Devon, Cornwall, Somerset, etc., with the northwest, which has the highest rates. And we don't over-emphasize these changes until we see other data corroborating it, or that we see it again in a week's time. But it is starting to fit together a piece. There might be these differences. And if you look at our other graphs, we are also seeing the north of England showing slight trends upwards as well. So it's sort of fitting together. This is the very first of them, but this is going to be a very useful tool, I think, in actually working out what's going on, in real time, in real numbers.
Now, Tim, there are...
And with real testing. Sorry, Sarah.
Yes, and with real testing. And I think that is very different from, it's very different from the symptomatic COVID cases, which there are quite a few questions from the eagle-eyed amongst us saying, our numbers have hung at around 250, 260,000 symptomatic COVID for the past few weeks. And actually that number looks like it's slowly ticking up this week. And a few people are asking why. Why is that?
Yeah, so I think the interesting thing about this new data is it's based on testing. And of course, we'll be looking at our symptoms in relation to this new testing data with an absolute eagle eye, because it did seem that as we get down into sort of fairly low prevalence amongst the population of COVID at any particular time, then the symptoms structure probably becomes slightly less accurate because it's picking up things like hay fever and so on. But it's really when, if things grow and if things extend in the population like they were sadly in March and April, then I think we will be able to pick up much more accurately from symptoms. But meanwhile, it's fantastic that Public Health England have joined with us to do this testing of anybody who has a new symptom. Doesn't matter what that symptom is, actually. They don't have to be predicted to be COVID, but they'll get a test or be invited to get a test, and then they can be part of this new estimation of incidence of new daily cases.
Yeah, and the other eagle-eyed will also notice that we've got a bit of a difference here between the number of cases. So interestingly, if you take the 10,000 a day and you multiply that by the average duration of symptoms of 10 days, which from our data, you get around 100,000 people in over a 10-day period that we think have the virus. 100,000, which is that's just for England, whereas our data was saying about 250,000 for the whole of the UK, and the other data that we have from our general swab testing, not just these new ones, everything together gives us a figure that is closer to 150,000 for the UK. So we think that our data around 150,000 is about the right number for the UK, and that our data is slightly overreading by about 100,000 people, our prevalence data. But we think the rates are accurate. So when we do see increases that are consistent with the other data, I think we have to take them seriously. So we're keeping a close eye on these recent changes that may end up being real, and that would be of concern.
Yeah, so some people are asking about R, Tim, and obviously we've been working hard to try and model R. Interestingly, we haven't put this up on our website or widely publicized it at the moment because our calculations depend on a number of assumptions and can be done in a number of different ways. And of course, it's possible as well that R is different in different population groups. And so I think you do have to always interpret R or estimates of R in relation to the population that they're done in and all the assumptions that go behind them, which might be why it's difficult to talk about in the same way as it is to talk about numbers of new daily cases.
So that's why we're focusing on actual hard figures of new daily cases. There are much less assumptions with that than all the other ones. Okay.
Great. So going into risk factors. Yes. So going into risk factors now, there's already been a question on, how much does age play into risk factors as well as biological sex, but I think, Claire, you can probably talk to that within the context of other comorbidities and health concerns.
Yeah, that's right. And thanks for putting up this slide because just like others, we do find within the data supplied by you guys that that there are various risk factors to do with comorbidities, but also age really is a very big risk factor. And we've put a preprint out, which is just under review at the moment still, which you can find online, which shows that we really have this exponential increase in risk of COVID, whether it's tested or whether it's our predicted COVID with age. Now, someone asked about a threshold of 70. Obviously within a continuous distribution, it's difficult to find a specific threshold, but 70 is about the time when really the risk starts to really escalate. So I wouldn't necessarily say that that's the wrong figure. But what I would say is that, of course, older people are very varied. They're very heterogeneous, as we say. And that means that one 80-year-old can be really fit as a fiddle going on marathons and so on, and another might be actually really frail. And so really the risk of COVID is very strongly related to frailty and other comorbidities that go along with that. And so I guess my question would be is whether we need to really use age as a cutoff, or whether we should use other more personalized factors like comorbidities or frailty. So talking about those, there's quite a number of these here, and we can talk about each of these in turn, can't we, Sarah?
Yes.
Yeah.
And I'm just replying to Alison, who has asked, are we talking about type 1 diabetes or type 2 diabetes? So today we're going to focus on type 2 diabetes, because we see the risk factors are higher within type 2 diabetes more so than type 1.
Yeah, I guess we don't have sufficient data from our app about type 1 diabetes, but I think we'll go on to talk about, I think anybody with diabetes may have difficulties with coronavirus, and may need to particularly be looking after themselves, monitoring their blood sugars and so on, to make sure that they don't need proactive care in hospital. So cardiovascular disease, the Chinese data pointed out very early on that there was an increased risk with cardiovascular disease. And I guess, Sarah, you were asking earlier about why that's the case. And of course, if you get any kind of infection, pneumonia, or even another sort of infection, if you have cardiovascular disease, you're less able to deal with that. Your heart is less able to deal with the strains that infection puts on you. For example, most people who have any sort of infection get a fast heart rate, and somebody who's got heart failure or somebody who's got ischemic heart disease will not cope with that increased heart rate so well. They might get angina, they might get worsening of their heart failure symptoms. So that's partly what it's about.
There's also some clotting stuff, isn't there, Claire, that people get these strange blood clots, and so obviously if you've got damaged vessels or arteries, that might be worse in those people. We don't totally understand that yet, but there seems to be other things going on rather than just strain on the heart itself that cardiologists are reporting. Yeah,
the increase in clotting is very interesting and has been reported not just in the lungs but in other places. And I guess people who have cardiovascular disease are likely to have a higher thrombotic risk. Of course, that could be mitigated if it's been diagnosed already, because they might be on medications like aspirin, clopidogrel, and we certainly would recommend people would stay on those medications at the moment. And that if somebody is going into hospital or unwell, then usually the doctors will be giving agents to help thin the blood, like heparin, low molecular weight heparin injected under the skin, in coronavirus and in all other acute infections.
Now, really early on, we got lots of questions around ACE inhibitors. And so, whether or not people should be taking them, are they good or are they bad? And I think first and foremost, we'll advise that no one changes their medication based off of this webinar, and also you should speak to your doctor before even contemplating that. But the thing that we wanted to talk about today was ACE2. Now, Claire, what is ACE2 and why does it matter in terms of ACE inhibitors?
Okay, so ACE2 is a molecule on the cell membrane which allows, which interacts with the angiotensin system, which is really important for blood pressure control and also other sort of responses to the environment. And it just happens to be that this is the molecule that is used by the virus to get into the cells. And I think the interesting story about ACE inhibitors and actually other risk factors for coronavirus is that there's this relationship between what those risk factors do to ACE2 seems to be something to do with why they pose a risk. And so with ACE inhibitors, ACE2 is generally upregulated actually, which potentially might mean that there's an increased early risk of infection, but it also means, and this is held out by other substances that change ACE2 expression, it also means that there is a reduced risk with ACE inhibitors of really severe disease. And so I guess, what's your bottom line? Obviously, all of us are much more concerned about the severe disease because that's the thing that's really important. And so it appears at the moment from the research that we have that probably ACE inhibitors are really good if you're going to get severe disease. And so that's why we would definitely say not to change them unless there's another reason at present. And the opposite can be seen in some of the other risk factors that we'll show you going forward.
Great. And now, there are quite a few questions coming in around, the difference and what we've seen in terms of the difference between type 1 and type 2 diabetes. I guess for today, we'll talk about type 2 diabetes. But what do we know about the risk for diabetics, and why is that so?
So Tim, do you want to answer this, or shall I take it?
Well, I mean, no one knows exactly why, because there's a lot of confounding issues, because a lot of the type 2 diabetics have other risk factors as well. But generally, the feeling is that they're metabolically unstable. They're running blood sugars and insulin levels that are abnormal. They have a number of other factors that, like heart, they often have heart disease as well, and some mild kidney disease, and they're generally at risk of a number of other problems. But it seems to be something particularly about the blood sugar, the fact that the metabolism is abnormal, that seems to sort of drive the virus into a bit of a frenzy and go for it. Because and there's also an underlying possibility that because the metabolism is abnormal, that is also influencing the immune system. And it's this link between the two that people whose blood sugars are fluctuating a lot has some interaction on many other things like inflammation and the immune system, and that seems to weaken the defenses against the virus.
Yeah.
But and people do present rather differently. So again, we've seen how the huge range of different presentations there are with diabetes, and that seems to be even different again once you add in that diabetes component. Claire, you want to come in on that?
Yeah, so certainly we can say that people with diabetes are more likely to present with symptoms relating to the gastrointestinal tract. So being off their meals, having diarrhea or abdominal pain seem to be things that are coming up much more in a diabetic group. And other things like confusion and fatigue as well. Adding to Tim's points before about the metabolic changes, and bearing in mind, Lynn Mooney has put on a question on the sort of chat about what happens if you're a diabetic, but actually you're really well controlled and you're doing well. Are you still at high risk? And what I would say is that if you are diabetic, I would keep a close eye if you develop any symptoms that you suspect might be COVID. I'd keep a very close eye on your blood sugar, because you might be able to detect things that are going wrong if your blood sugars start to be a bit more erratic or going high in particular. And that's what doctors are finding, that the diabetic control becomes really difficult in severe COVID. And then people actually need to go into hospital and seek care. So I think if you're a diabetic who's well controlled, that's great. Just maybe keep an eye on your blood sugar if you feel unwell. And think the
overlapping link with the gastro symptoms is quite interesting, because people with diabetes, type 2 diabetes and with overweight, obesity, do generally suffer from gut health problems. So the microbiome diversity is generally lower. They have less of the beneficial microbes, which are generally protecting the immune system. So increasingly, that's another factor, as well as having the immune system on its own, having poor gut health and microbiome deficiencies seems to be another theme that's emerging from this, explaining why you are getting these different at-risk groups.
And Tim, are you or any of your team members going to be doing any research around the microbiome as it relates to COVID?
Yes, so we are in several subgroups. So the twins, so we're looking at all twins in our study who have also in the COVID Symptom Study are having microbiomes tested, and we're looking to see whether that affects the directly. We're also linking up with other cohort studies that are doing this as well, that we'll be able to link these up. So there'll be some direct work where saying, well, do your microbes directly affect your risk of infection? But also, I think we're increasingly looking at how the immune system might be the intermediary. So people with certain microbes have a certain immune cells that either are high or low, and that could put them at extra risk. So we're looking at it a number of ways.
Yeah, it's really exciting that we've been able to launch the app in Sweden, as I'm sure many people will know. And our collaborators in Sweden are also very interested in the microbiome. And so we'll be looking at the data that we can have from the UK together with data in the US and in Sweden to see whether or not these links with the microbiome are recapitulated across populations. So that's really good international research.
Yeah, and the good news is if we do find something concrete, it is something you could do something about. It's not to change your genes, but again, you can change your microbes through diet and other lifestyle effects.
Absolutely, and quite a few people have been asking in the Q&A, like, are we looking at research from other countries? And we've got a few scientists at the University of Nottingham that are looking at the Chinese data, like Claire and Tim just said. Our app is in Sweden, which hopefully in the coming weeks we'll also do a webinar where we talk about some of that data in comparison to the United States and the UK as well. Yep. So moving on from type 2 diabetes, there's quite a few questions around asthma, smoking, lung disease. What are the main risks here, Claire? First within smoking, and we've just published a blog post on this today. And I've just realized.
So we put out a preprint article yesterday, which is referenced in the blog post, and we've submitted that for publication. And what we see is that if you're a smoker, you have a much higher risk of having greater symptom burden, and also greater risk of hospitalization with coronavirus. So, and the other interesting thing, we were talking before about ACE2. Remember, ACE2 is this molecule on the outside of cells, including in the lungs, which is the entry portal, as it were, for the virus into cells. And we see that actually in smokers, that ACE2 is reduced in various tissues. We're going to be looking into that more closely, but again, there seems to be this relationship between actually reduced ACE2 might actually protect against the very early infection or casual infection, but then becomes a problem for the management of the disease going on, and leads to the potential for this, cytotoxic and angiotensin storm, which might be really important for severe disease. So watch this space. I think that's going to be what comes out of the smoking work, which has. Do
you think that's related to the ACE2 inhibitor stuff? Is there any parallels there?
Yeah, there's parallels in the sense that smoking reduces ACE2 and is associated with greater symptom burden and severity, whereas angiotensin converting ACE inhibitors increase ACE2 and are associated with decreased symptom burden and severity. But both of them, the opposite effect for sort of casual infection with the virus. So I think that's what the story is emerging here, that it's quite a complex relationship with ACE2. But really what all of us should care about is that more severe end of the spectrum in terms of our own personal risk. But we need to be aware, I suppose, of the more minor infection in terms of public health and spreading of the disease. So that's the idea, that's where it is about smoking. With our data, we do show very clear increased risk with lung disease and COVID. And I think that's also come out of other work from other places. And possibly more so in our data, because we included asthma and milder disease within our definition of lung disease. And I think more work will come out about exactly what the risk is in asthma. But I think asthmatics do appear from our data to be at increased risk of coronavirus.
But as not as much, we don't think, as for other lung diseases. Is that right? Or we're not sure yet?
Yeah, I think there is an increased risk. I think we can't really quantify how big it is. Obviously, there may be many people with asthma who are really quite healthy otherwise and are quite young. And so because of the fact that they're healthy otherwise and young, they don't have so much risk as somebody who's got chronic lung disease, who's an older person who has other multimorbidities.
There's a question about bronchiectasis, and I don't know if this is something that we can speak to, Claire.
Bronchiectasis, yes, I've come across that question from many. So bronchiectasis is a condition where the actual architecture of the lungs has been changed, for example, by previous infection. And I think, there are a number of respiratory physicians who are very actively involved in research to look and see whether or not this kind of thing could be as a consequence of coronavirus. But certainly people with bronchiectasis tend to have altered secretion flow within the lungs, which means that they're more at risk of other infections or bacterial infections. And I think probably they're therefore more at risk in the case of a coronavirus as well. And so, yes, people with bronchiectasis are probably at higher risk, although they're not in the very highly shielded group.
Great. So moving on from lung disease, there have been quite a few questions about obesity, and actually, some people have asked if, are we seeing similarities between people who have type 2 diabetes with people who are obese?
Yeah, well, the two are very closely related, certainly in most Western countries. There are always exceptions, but in general, the people that are having the problems on intensive care units tend to have a very high proportion are obese and also have type 2 diabetes. But we are seeing some people without the diabetes, but with the obesity in those high risk categories as well. So that you don't have to have both. But I think what we do know is that both of these conditions do cause metabolic upsets, and that just by having that much fat tissue, even if your blood sugar is reasonably normal, does have other effects on your metabolism and on your gut microbes and the way you respond to infections with inflammation, etc. So I think all of those things, plus the fact that you're more likely to have low-level complex diseases as well, because it often doesn't occur purely on its own, makes these people susceptible. So we think it's some underlying metabolic or immune problem that links all these things together. And it's not a surprise that there is a link between the number of cases in the countries that have lots of skinny people versus lots of overweight people. And you can draw some rather crude statistics about that, and make people believe that's also why you are seeing some of these social trends in deprived areas, because obesity is also very much a social problem, and certain countries have much more of a diverse social mix, and we'll see these deprived subgroups that also have high levels of obesity, and they're the ones having the high death rates. And that's also true if you look in this country, in the populations. And this and in the US particularly, where it's a real, they have their own pandemic of obesity. We're seeing these rules about this not being a serious disease in young people not being true because of the number of obese young people in the US. And this graph shows really the differences we're seeing. So on the left-hand axis, you can see BMI, and as it goes higher, that means you're more overweight, more obese. And on the right, how old you are, and basically the risk should be going up diagonally. And you can see that you can have your risk either from age or from BMI, and there's an overlap in there. So, but generally, if you take someone age 40, you'll see that BMI is certainly a much bigger risk factor. But if you're a skinny 80-year-old, actually, you might be doing better than an obese 40-year-old.
Yeah, and this graph is so striking, isn't it, compared to our graphs in the UK, Tim, which generally, within each sort of decade of age, generally the BMI goes up. Whereas here in the US data, there's a trend where actually it's the younger folk that are more at risk of obesity. Yeah. That's the point here that we're making with this graph.
And I think what we don't, our data, is very good at showing who gets the symptoms. So the fact that we're finding out that overweight, obese individuals are actually getting more symptoms, getting more infections, is also interesting, because it's not just in the intensive care unit. It seems to be at every step of the infection seems to be worse. And we don't really understand why that is.
Here are a few hypotheses, but I guess lots of people will be testing this, including ourselves, and also looking at to see whether or not we can use, for example, our data linked to the Twins UK cohort or other cohorts which actually have more biological data collection to try to unpick this risk, which I think is going to be really important going forward.
So Susan has asked a question. Is there a difference between fit fat people or unfit fat people?
Well, we don't measure fitness of a person other than their dependence on other people. And of course, yeah, it's possible to be actually, a sort of, weightlifter athlete and have a high BMI, but actually be very fit. We can't really pick into that variability within our study. I guess the chances are, though, if you are fit, if you're physically fit and able to sort of, do a high level of physical activity, you'll be much better off if you face a coronavirus severity, because your system will have more resilience in it.
Absolutely. Should we talk about some of these risks with obesity? And there are quite a few questions again on, if I have diabetes or pre-diabetes, but I'm not obese, am I at the same risk level as somebody who is obese? Tim, are you?
Okay, sorry.
Sorry.
Okay. So, well, we can't compare these things directly. So it's a bit like that. But obviously, it seems to be a gradient that basically the more overweight someone is, the greater their risk, and you've got these competing other factors going on. So if you've got diabetes and obesity, it's greater. It's highly likely that fitness will mitigate that in some extent, and that might be the amount of lean muscle you've got as well, which generally is good for the immune system. Other factors like your diet might also be important. So you can be overweight, but if you're on a healthy diet, that might mean your gut health is better, and therefore your risks are lower. I think in the future we will be able to get a more precise breakdown of these risk factors, and of course we haven't really mentioned race here at all, and that's another one that
I think it comes on.
Yeah.
It's something that's next. Is it the next one, Sarah? Ethnicity. There you go. It is. Our study is not alone in the fact that it finds that actually if you are Black or Asian or another ethnic minority, you have an increased risk of coronavirus and serious infection. And I guess what we're just writing a paper on at the moment is trying to unpick why that is, because of course there are significant social inequalities in the UK, sadly, for people of Black and ethnic minority groups who tend to live more in urban areas, tend to work in key work professions, who might not be able to isolate, and who potentially have other risk factors related to that, which are potentially co-morbidities that are common, including overweight. But it looks like when we actually try and account for all of those things, there is still a little bit of an increased risk for people of Black and ethnic minority groups. And I think there's really interesting questions about what biologically that could be driven by. And so we're certainly looking into differences that might relate to, for example, vitamin D. That's a big question that everybody has. I'm sure you guys have as well. About whether or not we know that people with darker skin create less vitamin D in this country, and so are often vitamin D deficient. But what we don't know is whether that's related to coronavirus. But ACE2 appears to differ in different ethnic groups as well. And of course, there are other differences. Here I put HLA, which is the human leukocyte antigen, which is really important for your immune setting, as it were, which can be different with different ethnicities. And so that could be one of the factors, but there are many others as well that could be underlying this as well. And so that would mean that even if you don't have comorbidities and are privileged background, you might still have an increased risk if you're from an ethnic minority group.
Great. I'm just looking to see if there were any questions around comorbidities as well. There was a question on whether or not we're working with the UK Biobank.
Yeah, so Tim, well, so we are working with the UK Biobank on many projects. In terms of linkage with the UK Biobank, for currently, we are not currently able to link, but we are hoping that we will be able to do so, because this will be hugely beneficial for the public good and research into coronavirus.
Great. So going into healthcare workers, there was an article that was published in the Times a number of weeks ago around the risk for healthcare workers. But Tim, it would be great to hear about some of the data that we found related to healthcare workers and some of the factors contributing to that.
Yeah, so we have over 100,000, maybe probably more now, healthcare workers on the database, which is probably the biggest set in the world that anyone has, and including a group in the US as a comparison. And generally, every healthcare worker was an increased risk of getting the virus. And there was a clear gradient between their risk and how exposed they were to actual patients and direct contact. And it went up to 12-fold for the group that were most in contact with potential COVID patients. And this is the first time really this has been quantified. It's been talked about, but no one's actually put figures on that. And that was an important finding, and it was similar in the UK and the US. So we think this is a general phenomenon, and it really underscores the fact that not just NHS staff, but also care home staff are included in this group of key workers that are, putting themselves at extra risk to do their job, and I think they need to be recognised for that. We also asked about PPE, this is protective equipment, and whether that was a factor in whether they were getting extra symptoms or not. And overall, Claire can interrupt me if she interprets it differently, but I didn't think that was coming out as a key factor in this. I think it was more the fact that these people were constantly exposed to lots of people in an environment that was full of virus was more important than it would have been dramatically different if they'd had PPE. And most people in the UK reported that most of the time they had adequate PPE. There were exceptions to that, and there were some regional differences as well, which Claire might want to comment on, particularly in care homes.
Yeah, so sure. In terms of that, we haven't yet published our paper on that, but it'll be coming soon, showing that care homes have a bit of more of a difficulty in getting adequate PPE than other places, and there are certain regional differences as well. And I think everybody knows that PPE is really important. But you did bring up the point, Tim, that actually the risk wasn't really all attributable to loss to not having enough PPE, the risk for healthcare workers. And actually the UK was at more risk than the US. The healthcare workers in the UK were at considerably more risk than in the US. And I think that's interesting to ponder on why that is the case. And I think that that's where point 3 really comes in, is that it's really important that we recognise symptoms which are less classical, so not fever and cough, but things like anosmia. It's really important that we recognise those in healthcare professionals, because what you might use your PPE to interact with your patients, but when you're with other staff members, you're not using PPE, and so you could be transmitting to your fellow staff members from one to t'other, especially if you don't isolate because you have, for example, anosmia. So we're really pleased this week with a lot of effort from everybody, all the way from you trackers, that the government has sort of finally recognised that symptoms like anosmia, loss of taste and smell, can be symptoms of coronavirus, because that means that then healthcare workers who have those symptoms that are a bit milder can actually isolate and not go and infect their colleagues at work.
Now, going back to risks for healthcare workers, Claire Newton has asked, with healthcare workers, are they at higher risk of just catching COVID, or when they get it, are they at higher risk of getting it more severely?
We don't see a severity connection with healthcare workers, and I think that's really interesting, because you might expect that they have a greater sort of like contact with the virus and therefore have it worse. But of course, healthcare workers on average might have different health effects, but we don't see a severity signal with healthcare workers.
Which is against, high-profile media stories would suggest otherwise, but actually when we've got this enormous amount of data, we can move away from the anecdotes and start seeing this. So, as we know, this is a very strange virus, and a few people are abnormally affected, and it's just a sort of numbers game rather than, and that's why more doctors, get in the news when they die of this, but we're not seeing that when we take the 100,000 general people out there. So that's they are obviously more exposed, therefore they will get more infections. It's not clear proportionally that they're doing worse.
So we just wanted to end on a note, thinking about, we've been talking about risk factors as it relates to coronavirus, but Claire and I, ahead of the webinar, we're talking about health debt overall, and whether or not people are coming to get treated based on thinking about their symptoms, and also, I guess, the impact to the health community at large, because for those people who might have prediabetes or other health conditions like cardiovascular disease, actually what we're seeing now is that less people are coming into hospitals or seeing their GP because people are worried about the strain on the healthcare system.
Indeed. So I think we're all worried about this, and I guess this is a good point to end on. Whether you have coronavirus symptoms or whether or not you have something else that you think it is a medical problem, I think really don't delay from seeking medical help. I mean, you know, we're finding that the average time to symptoms to going to hospital in people on the app is actually sort of 13 to 14 days, which is a long time to be sitting with symptoms. But of course, what you're talking about, Sarah, which is this health debt of people actually not going to hospital for other medical conditions because they want to save the NHS. I think now is the time to really, present if you're worried. The health service is working very hard to find ways of safely seeing people using potentially more long distance technologies, telephones, over video conference facilities, as well as making sure that people coming to outpatients and so on are socially distanced. So I think don't be afraid to speak up and go in and deal with any health problems that you might have, because of course otherwise we really are going to have a third wave of difficulties. And again, it's those comorbidities we were talking about before that give people an increased risk of coronavirus, but also give people an increased risk of all sorts of other things. So do present.
Or certainly phone your GP, because a lot of GPs are actually saying they're less busy than usual. Not all of them, but because people are even frightened to ring them, even there's no risk about getting advice. So, don't, if you are having a problem, then do talk to someone and get advice.
Yeah, so as Judith was saying, don't rush into hospital because people caught it in hospital. No, of course, I guess there is that thing. That's why Tim's saying call the GP or use 111, etc. But within hospitals, all the hospitals have got really carefully stratified systems now where there's highly shielded areas where they can deal with people who are at high risk, for example, people who are on immunosuppressant therapies and so on, to really keep them shielded. Then there's sort of suspected areas, then there's green areas, and then there's red areas, so COVID areas. So that I'm pretty confident that if I was ill, I could get the healthcare I need.
Tim, we'll end on a few questions on track and trace. So Nigel has asked, how low must cases get for track and trace to be a practical solution?
Excellent question, Nigel. I don't know the exact number, and it sort of depends on the resources that there are in place to deal with them by region. So at the moment, we're seeing 10,000 new cases per day, which, if it's going down slightly, is still going to be a fairly major burden on these 20,000 tracker people to work with. But I think we're at the sort of levels where it's possible to now track and trace nationally. I don't think it was possible before. So I think once you're getting below 10,000 new cases a day, it's possible. I think the system would still be too stretched to deal with them at the moment. I think they might have done better if they'd got all the people who volunteered to help in the NHS to be trackers, to be honest, which was 250,000 people. But it is what it is. So I think it's going to be effective. I would, on the back of envelope calculation, once we get down to about half of that level, about 5,000 cases a day, then I think it would be effective. But of course, it should be done regionally, not nationally. And it does depend what the systems are in place regionally. And I know that Scotland and Wales have concerns, and that's one reason they haven't left lockdown quite as quickly as England, because they don't feel confident that they have all the systems in place. I think that is very much the key here, is what is your local council doing? What is the setup to isolate What is the system about being able to shut down, say, a school if there's an outbreak? All these things need to be in place. It's not just about one system. It's not about the, NHS app. It's not about random testing. It's all these things together. So I think we're getting close. I think at the moment they would not be able to do a very good job, but I'm hopefully in a week or two the numbers will be down and it will be possible.
And then final question for you, Tim and Claire, to talk about. What questions are we going to be adding into the app over the next few weeks? What else are we trying to learn from our contributors?
Well, we've got so many questions we'd love to ask, and we're limited because it's an app and not a telephone directory. And so we've been told now we have to delete a question in order to add one. So that's the other thing we're going to have to do, is trim it, keep it trimmed down. We want to ask about vitamins next. That's and supplements. That's going to go on, and that's been a lot of interest in that. And we've got a whole range of other ones which are competing at the moment to see which ones go first. Claire, what's your favourite one to go next after vitamins?
Well, one thing that I'm really interested in is the longer term symptoms of coronavirus. And obviously we're tracking the symptoms as we currently devise them that we think might be for acute coronavirus. But there's also that thing about impact and whether people are able to get back to normal activities. And I think we'd like to do that at some stage, but the timing of that is key, isn't it? Because people are saying that there's maybe a chronic fatigue type syndrome that could be happening in some people.
Yeah, well, we might have another whole webinar on the long-term consequences, because we're getting so much supportive mail about this issue on this 5 or 10% of people that are seeing these long-term symptoms that may be a different subtype of the disease itself. And I think it does need its own research group. But we're also going to look at mental health. We think, the negative effects of isolation as well as the disease itself, trying to balance those out. People have told us we should be asking more about emotions and feelings and depression. We're going to ask about diet and gut health as well in coming weeks. All of these are very tough to do, so we may have to refer people to another website to fill in these forms because they may not lend themselves to a one-word answer or a tick box. So wherever possible, we're trying to go for a short question, but we're struggling about when things get a bit more tricky. So hey, watch these pages. We will be doing changes, and we should also be hopefully soon ready to report on the HRT question that we asked about 10 days ago.
Absolutely. I think there's a wealth of data that the team is analyzing and literally working through the weekends to analyze and to update the website. And I think a huge thank you from all of us around the donations that have gone to the COVID Symptom Study. Those have gone to, they will be going to the Chronic Disease Research Foundation and funding researchers at King's, in addition to the team at Zoe, who's providing the technical expertise and the machine learning background to help us predict these cases of COVID. And so if you have donated, thank you very much. If you haven't yet and would like to, we have a Virgin Giving page, which you can find via our blog. And if you do want to find that, you can visit the web address that's on our presentation just now, covid.joinzoe.com. And there's a post around donations on the blog that you can find there. I'm afraid that's all the time that we have for today. Thank you so much for your very intelligent questions and thoughts as we've gone through this presentation. And a huge thank you to Claire and Tim Spector for your time today. Brilliant. Thank you, everyone. We'll see you next week with a new webinar that we'll be putting together, and hopefully we'll have a link up on Tuesday to register for that webinar via the blog. Thank you very much and have a wonderful bank holiday weekend.